So we have that all over the place in the body where nerves are passing through muscles and fascia. Even if they're not passing directly through the belly of a muscle, they might be passing through a tunnel between muscles. So another classic example would be the brachial plexus, where we've got all these nerves, C5 to T1, passing out through the scalenes, down under the clavicle, under pec minor, down to the arm. So what's going to happen is when we have hypertonic muscles, changes in posture, changes in posturing of a joint, we can compress these tunnels, compress these nerves. And the first thing that's going to happen is when you touch a nerve, it's going to start reporting some pain. And if we leave that there, it's going to become pain sensitive. So you would have seen with the brachial plexus, for example, neurogenic thoracic outlet syndrome. Mm-hmm. So you touch gently here and the patient immediately says, ouch. That shouldn't really be the case. So if you imagine if you tried to drown me, you shouldn't stick my head underwater and 10 seconds later I'm dead, right? I should have a few minutes in me before my brain says, okay, enough. It should be the same with nerves. So if we were to compress a nerve at the carpal tunnel or brachial plexus, you shouldn't immediately say, ow, I can feel it in my arm, or ow, my arm's gone numb. When we have that scenario, we know that there's probably already some level of compression. When we compress a nerve, we reduce its blood supply, we reduce its ability to get rid of waste products, so we basically get edema. And so when we press it, the nerve is already a little bit starved, and I put a little bit more pressure and it goes, I'm dead. So we have that throughout the place, throughout the body, and obviously the brachial plexus is a great example. But if we come back to the head, we have that all over the place. When we were talking about chronic pain earlier, I talked a little bit about dermatomes. So let's say I sprain C5. What you're going to start seeing is that I will initially say it hurts at C5, and then as that sensitization comes in, now I'm going to have pain into my shoulder. So now when you come and touch my shoulder, I'm going to say it's sensitive, but it should only be in C5. If you come down to the C6 dermatome, it should be fine. When secondary hyperalgesia occurs, or we have that central pain sensitization, CPS, if you want it in your notes, and PPT is pain pressure thresholds, just in case I start tripping over words, I might start shortening them. What will start to happen is the pain sensitivity will spread down through the dermatome. So first C5 hurts, and then we're going to get pain into C6, then C7, C8, T1. Now, the patient will complain of pain in those areas when it gets severe enough, but initially they might just have more pain sensitivity. So you'll come down through these areas, and as you squeeze them, they'll say, oh, yeah, that's actually really sore. Now, we're not just looking for, it's a bit tight. We're looking for, ow, that hurts. Oh, yeah, that's sore too. And we'll show that later. That is literally what you're looking there, is you're seeing the physiology of pain spreading down through the dermatomes. And unfortunately, it goes all the way down. So you could have someone who has whiplash and now they have pain all the way down to their back. You'll see those reduced pain pressure thresholds all the way down to the legs. So you can squeeze anterior tib in someone who has whiplash and they'll say, ow, the same way they would with their shoulder. So we're seeing that pain progression. The beauty of it is that when you treat them, and if you're doing a good job, you'll see it regress too. So they'll start saying, no, not so much. No, not so much. No. Oh, yeah, that's still quite tender. And then hopefully a few weeks later, you can get back up into the shoulder. So hopefully what you should literally see is it reducing. Now it's interesting from a diagnosis point of view, because how many patients do we see with radiculopathy, but their sensory, motor and reflexes are all normal? But based on the symptoms, you've got neck pain, you've got radiating arm pain, it must be radiculopathy. The question is there actually any nerve involvement there? Are we compressing a nerve at all? Or is it just they've hurt their neck, it's been painful for a while, now they've got this radicular pain? Right.